So for those that heard me speak earlier today, there's a lot about sickle cell that I'm fascinated about. And when I was asked to join this panel about the concept of high quality inpatient pediatric sickle cell disease care, I struggled a little bit. I was like, okay, what are the things we should focus on? And also with a short time, let's try to cover as many things as possible. Thank you. So I'm going to touch on a few. I think you're going to hear from our other speakers on the panel too, where we all overlap, and then maybe we can have a good discussion during the Q&A. So I'm a pediatric hematologist. So for the adult hematologists in the room, I apologize that I won't dive as deep into that. I think there's a lot of shared things, though, that both spaces can rely on. But I definitely view the world through that pediatric hematologist lens. And as mentioned, I am an advocate for sickle cell disease, having lived with it and just various life experiences. And then these are some of the committees that I serve on that I wanted to just mention. So whenever somebody talks about a hospital or inpatient unit, I think one of the biggest things that come up is this concept of utilization. How much are patients costing the healthcare system money by utilizing that healthcare system? And when you look at an analysis of who are the people coming into the hospital, you can break them into these categories. There's this category of high utilization, and some people even use the term super utilization for a few patients, where the top 1% of the population of that utilization spectrum in a hospital, they are using more of the resources. So this is a very tiny table, but just for, I'll say just one at the bottom, 50%, most people are not having that much healthcare costs. So you can see that their healthcare costs are less than, and this is dollars, American dollars, $1,500 or so. But then when you go to the top 1%, you're seeing healthcare costs like $90,000, $80,000, depending on the year. When you look at a hospital administration team, they're going to say, well, which of these were preventable? Which of them were avoidable? Which one will cause them to come back in 30 days? Like, all those words that drive a few of us crazy, like, our 30-day readmission rate. So for sickle cell disease, I've been fascinated by what is that concept of avoidable versus unavoidable, and how we sometimes categorize or penalize patients for those. Whatever lens you sit on, whether you're a hospital administrator trying to drive down costs or a patient trying to make their life healthier, identifying the people in the top category, high utilization, it's important because that helps us decrease burden and provide targeted care. So referencing this for sickle cell, this is also numbers that come from the United States. A few years ago, it was stated by one of our national health agencies that the cost of inpatient care and utilization that's not outpatient-based is $811 million for sickle cell disease. And this graph is not representative of any true number. It's just that most of those admissions are related to pain, Vaso-Occlusive crises, or things related to having a crisis. So pain is the most frequent reason why you'll see a hospital encounter for sickle cell disease. But that's not the only thing that happens to people with sickle cell disease. And I proudly took a cute little child picture instead of the, usually the older adult, they're kind of boring looking, whatever. That's adorable. You feel happier looking at that child. So this was published in 2024, and it's a renewal of a healthcare guideline that we use in the United States. And I love the fact that they chose to have this portrait of a child. But all of those pieces that are listed out are things that can land you in the hospital, especially the ones with the star, things that can cause mortality as well. So you have acute chest syndrome, you have splenic sequestration, priapism can land you in the hospital, avascular necrosis can land you in the hospital, renal failure, so many reasons for that $811 million. So here's another hidden reason. The overlap between, again, this biology of the disease, acute chest syndrome, pain crisis, versus the non-medical drivers or the social determinants of health that also overlap into that person's space. And I was asking people, are you from Canada? Are you Canadian? So I don't know how many of you are Canadian versus American in this room, or if you're a little bit of both. So I don't know if there's a different term for this in your land. But if you look at just the list, you'll be like, yep, that impacts my patients. Limited access to the sickle cell clinic. So-and-so lives 3 hours away. Distance, transportation barriers, financial coverage barriers. And again, I used to romanticize Canada. Everybody has healthcare, so things are perfect over here, right? Managed care referral process. How do I get a subspecialist? How do I get to the ophthalmologist? Academic attainment, vocational stability. All of those things matter. Do I have access to the special insurances that we were talking about? And then for sickle cell disease, the lack of trust in the healthcare system, racism, bias, and stigma that overlap with the disease spaces also play a role in this non-medical driver of health. So high quality healthcare for sickle cell disease is important because it's important for any patient who has a complex disease that uses more resources. Acute chest can land you in the ICU. Stroke can land you in the ICU. Patients with unmet mental health and social needs use more resources. Patients with unmet medical needs use more intensive resources. And then when you look at ways to optimize how to do better, multidisciplinary models has seemed to be the way to go. Like having care management models that involve more than one lens, multidisciplinary pain clinics, for instance, and then also clinics that focus on preventive care. That was another, I'm just like, this whole table basically gave the presentation. We were having a lovely discussion. So high quality care for sickle cell is important. And I'm going to use the title of this presentation to emphasize the different themes. So we're going to start with coordination. You want to deliver high quality inpatient pediatric sickle cell disease care. What things are important for the coordination? First, it's orienting the family and the patient to the healthcare system. It's a complicated healthcare system. It's a complicated hospital stay. And so there's the simple things like parking, food, hygiene, simple in quotes, parking, food, hygiene, comfort, support resources, making sure the family knows, in addition to the healthcare plan, what else you can provide them support. And you need dedicated staff. I don't know the term for your hospital. Even in the United States, we use different terms for these roles: case manager, nurse coordinator, patient navigator, social worker. You need somebody that is not just dealing with their healthcare part of the needs, but also those medical drivers of health. And then begin with the end in mind, which in our world for inpatient is discharge planning. The moment somebody enters the hospital, you think about what is the discharge goal, if you can. Sometimes it's a little bit up in the air. So beginning with the end in mind, those are all, basic coordination steps. But you can't forget patient experience. And again, I have no shame throwing cute baby pictures in front of you all day. But my husband's a chaplain, and so he's doing a rotation now focused on hospital chaplaincy. He's done military chaplaincy. But I appreciated the role of a chaplain as well as that of a patient family advocate. Again, might be different terms over here. Child life specialist, therapy. And so anybody who's a pediatric hospital person, you may resonate with these. The adults are like, what is this? What, y'all, therapeutic music, what? Pets? Why? And then that support. You've been in the hospital for this many weeks. How are we gonna get you back to school? Your homework, vocational support. Mom and dad missed work, or again, for pediatrics, but some of the young adults, they have jobs as well. And then, of course, financial support. So when you are thinking about patient experience, I think the first rule is that don't presume that you know anything about the patient experience. You're gonna have to ask them. I think a patient or family advisory board is a key goal. This is still a goal I'm trying to get to for my hospital that represents sickle cell. It doesn't necessarily have to only be sickle cell, but just make sure that that voice is captured there. And then things that I've had to knock on before, from chaplaincy to family advocate, I feel like those are those secret ingredients that help a family have a better experience in the hospital. And so this list is not exhaustive, but I think you get the idea. So you are knocking on the door of experts to try to figure out how to get a patient experience. You have staff dedicated to the coordination steps. How do you improve what your hospital told you guys are top in Ontario? You have all these award systems. In America, it's a big thing. We are the blah, 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 so-and-so institute's #1 hospital for, giving heart attacks better, all sorts of things. For us, we have things like U.S. News World Report. We have the so-and-so's Children's Hospital Center Award, Blue Bonnet Medal, whatever. So your hospital cares about getting on those lists. You need to show them that, hey, you got on this list maybe because of your care for asthma only. These are all these other diseases. For me, it's a pet peeve of mine. All the oncology awards, Hem-Onc wins the award, but it's really for their excellence in oncology side, not really their excellence in hematology side. So first, you have to figure out, is there a standard or a goal? With sickle cell, we all know that there's been a disparity there. But now we're doing better. We have some evidence-based guidelines. We have consensus guidelines. And there are quality benchmarks that we can now overlap into the sickle cell space if we haven't already. Embrace quality improvement. I first heard the word quality improvement in residency, and it was one of those things that would make me shudder each time. It's like, quality improvement, oh dear. PDSA cycles, all of it. I've learned that this is important. You have to test out small changes to help yourself get better. And depending on which quality improvement model you've been exposed to from the Plan, Do, Study, Act methodology or the Lean methodology, and for those that recognize these terms, Lean was borrowed from Toyota. How to make beautiful cars that don't crash and kill people? You need quality improvement for that. Hospitals have learned the same. And then it requires a dedicated team. So you do need that QI champion, the person that's gonna bring the energy. You need your subject matter experts, everybody from the medical assistants to the nurses to the providers. And then figuring out how to capture the patient and family input is important. But you also need support. I don't like the QI projects that are just supported by wishes and dreams. You need a sponsor. Your leadership needs to support you guys. You need time. You need sometimes money. You need data support in order to get your goals. So how to begin? Well, find the standard. For you in lovely Ontario, you have the CAN-HEME consensus statement, which I think y'all are either going to talk about or you talked about yesterday. No.
There's also an Ontario quality standards.
Oh, okay. No. Did I cross into territory? I showed the wrong picture, man. I just saw the maple leaf and I thought y'all would be okay. But yeah, so go to the people who know that there are standards for Ontario and you talk to them. But you need to figure out how to get started, and then you can tell your leadership, well, if you really want to be the top, this is what the top means. Okay, so that's my part. Looking forward to further discussion.
Thank you so much, Dr. Fasipe. I'm going to ask Dr. Sarah Patterson to come up next. Dr. Patterson is an adult hematologist at Hamilton's Health Sciences, specializing in red blood cell disorders, including sickle cell disease. She is the director of the McMaster Adult Hemoglobinopathy Clinic and has a strong interest in health equity and health policy. So, Dr. Patterson.
I'm going to steal the microphone because I'm afraid of the other microphone. Awesome. Excellent. So I have a mammoth of a topic, and in the next 15 minutes, we're going to talk about inpatient management of adult sickle cell disease. Just very, very quickly. I don't have any particularly relevant conflicts of interest, but I do some work with the Ontario Lab Medicine program in hematology, and I'm a sub-investigator on a couple of trials, but I'm not talking about those today. What I want to talk today is very briefly in a relatively practical way of I have somebody in a hospital or presenting to a hospital with sickle cell. What do I do? So initial assessments, first principles, and some complications. Why do people present? Most people present with pain. So vaso-occlusive pain crisis is the #1 reason that people present to hospital with sickle cell disease, but it's not the only complication. People can present with acute chest syndrome, with fever or sepsis, particularly due to a spleen that doesn't work, that interferes with your body's ability to fight infections. Splenic sequestration, when the blood gets stuck in the spleen and it expands and it causes pain and it causes a sinkhole for blood, dropping your hemoglobin and giving you symptoms of anemia. People can present with stroke, hemorrhagic or ischemic stroke with neurological dysfunction, which is a medical emergency for anybody, but especially for someone with sickle cell disease, you need an urgent exchange transfusion if you can get it right there and then. People also can have organ dysfunction in one or multiple organs. So it's important that when somebody presents, that we take a minute to say, hey, is this pain? Is this pain plus? What am I doing? How do I go about this? And making sure that we're looking for what's happening now, but also what might be happening during the hospitalization. I like context. What I do is because of the people that I have the opportunity to work with. So I'm going to sort of use this 26-year-old female with sickle cell disease who's on hydroxyurea, but unfortunately has completed their supply, did not have access, and has been off for a month. They've had 2-day history of back and thigh pain. It is extreme. At home, they take about 2 milligrams of hydromorphone, so that's their home dose. It's not working, they're not okay, and they present to hospital. We have some Ontario quality health standards. People who present to hospital should be a CTAS 2. This is an emergency. They should be seen within 30 minutes of their triage. There should be access to pain medication within 60 minutes of presenting to the emergency room. We have that multiple different reasons for acute presentations. This 26-year-old has pain. Thankfully, this person had normal vitals. They do not have evidence of acute chest in front of me now, which is excellent. Doesn't mean it won't happen during a hospitalization, but at least for right now. So I'll take that differential and make sure I'm applying it to my patient. I do like to have some baseline labs. There are no labs that are diagnostic of a pain crisis. You can have labs that look exactly like your everyday labs and you can have a pain crisis, or you can have labs that are significantly different than your baseline. It's useful to know where the labs are now, where the labs are baseline, and where they are going through a hospitalization to help guide management. I particularly like to have a sense of where is your hemoglobin? Am I going to panic because somebody's hemoglobin is 68? Not if their baseline is 70. Don't just transfuse for no reason. But I also want to see hemolytic markers. I like to have a baseline hemoglobin S level so that if I do need to do something like a transfusion or an exchange transfusion, that I have some baseline data to help guide those decisions. Hemolytic markers, checking organ function with liver enzymes, creatinine, etc. If you have somebody presenting with a broken arm, maybe you want to do an x-ray for that too. So remembering to look for sickle cell related complications, but remembering that sickle cell happens in humans and humans may have other issues. So it's also important that we recognize and look at our sickle cell and manage that appropriately, but remember that people are people and may have other issues and not have those blinders on. I hate D-dimers and CRPs, which is one of my pet peeves as an adult hematologist. A D-dimer is an excellent blood test to tell you if you have a blood clot, except if you're inflamed. And I gotta tell you that most people who are coming in excruciating pain in my emergency room are probably not gonna have a normal D-dimer, which means that people are like, oh my gosh, this person's gonna have a blood clot. And yes, people with sickle cell have a higher risk of blood clots. But doing a CT scan to look for a blood clot in the lungs in every sickle cell patient at every presentation comes with risk. Important thing to have on our differential, but not everybody needs a CT scan every time they come to the emergency room because that amount of radiation could be significant. So we need to make sure that we're using our diagnostic tests with appropriate context. Can be a really useful test, but a D-dimer in and of itself is not always helpful because it's often elevated as an acute phase reactant, and likewise CRP, a non-specific marker of inflammation. I tell you, we're gonna go real fast. Individualized care plans. So people, when they present to the emergency room, it's really helpful if we have some guidance on what works for this patient. And if we can have that in the patient's chart so that the person who is sitting with their entire body screaming in pain does not need to say, please, sir, I would like 2 milligrams of IV hydromorphone. which is great when people can. When people are able to advocate for themselves on the life experience that they have, because I can promise you the adult coming to my emerge, it's not the first time that they've had pain. And they do know what works for them. But having that in a chart that documents it, that provides support, that helps remove the stigma of somebody saying, I want this dose of opioids in this direction, which is very appropriate in sickle cell disease, but does flag healthcare providers who are not familiar with this person's just opioid seeking. And that is not the case in our population. The risk of opioid use disorder is not higher in people with sickle cell disease than other disorders, and they get inappropriately labeled at times. So an individualized care plan is really important. How do we do this? The game is out. There's lots of data that they're helpful. Lots of institutions do them in different ways. I enter them manually in 2 different EMRs for my patients when they've had 2 or more emerge visits a year personally. Order sets are a very nice way for an organization to have a standardized approach to the management of sickle cell care. The core approach to a vaso-occlusive pain crisis, which I will talk about more, is adequate and early analgesia, so lots of pain control coming. We want people to be euvolemic, not dehydrated, not overly hydrated. I will go faster. Making sure that they have enough oxygen, because low oxygen makes sickle cell angry and makes those cells sickle more. And if they're on disease-modifying therapy, continuing that to help suppress the sickling and keep people healthy is super important. Pain is like a mountain. If you miss treating the pain on its way up, it takes a lot more pain medication to get your pain from a 10 or a 12 than if you can knock it down at a 4. Our patient came in with 2 milligrams of hydromorphone, so I'll usually start with 2 milligrams IV as a starting dose to try to sort of effectively double the dose of opioids to see if I can calm things down, and I like stacking. Giving a dose, reassessing in 15 to 30 minutes, and giving more as needed. IV administration is wonderful if you can get an IV. Intranasal, oral, subcutaneous, IV, all ways to get pain medications quickly. And if you have access to a PCA, a patient-controlled anesthesia pump, fabulous, though the access to that is not the same across different hospitals. Fluids are great. If you're dehydrated, you can give someone some IV fluids and bring them up. But if you give too much IV fluids, you can drown people's lungs with volume overload. So please, gently fluids. Fluids to target euvolemia, fluids to correct hypovolemia. And after you've gotten them up to a normal level of volume, a hypotonic solution thereafter for maintenance, if the person is not drinking well, is ideal. Pain is serious, pain is severe, pain is often the first cause for presentation, but many people will develop complications even in hospital. So people may not present with acute chest, but they might develop it. So we want to be constantly reassessing our patients through their hospitalization. Oh, your pain is much more severe today. Oh, you can't breathe. Oh, your oxygen's coming up. We need an x-ray. We need to see if this is acute chest. We need to revisit what is happening with our patient, going back through that differential diagnosis. They're listed here for your edification. Again, I want to remind people that not everything that people have is related to sickle cell. So sometimes we have people who have, say, rheumatoid arthritis, and they come and they have really terrible pain and they have swelling, and this is a problem, and you're like, yeah, okay, I mean sickle cell, but like, is this just sickle cell? We need to remember to look at the whole human, because that's also important. I'm going to summarize here. This is a huge topic, and I can and will talk about this all day, every day, because I think it's so important that we remember to treat people who are presenting to the emergency room with sickle cell with the appropriate dignity, with listening to people, and making sure we have an organized approach to respect the patient as well as their medical issues. We want to use early rapid analgesia. We really want to bring that pain control down, because the more effective we are at controlling that pain, the less complications that people have, the less time they have to spend in hospital, and the more they can get back to their everyday life, which is the whole point of this. Using a multimodal pain approach, so making sure we're using different types of medications to try to hit the pain from different angles if we can, because that can help reduce the side effects of any single pain agent. We want to use individualized care plans when we can to help support our patients and get them the effective management. Continue some disease-modifying therapy and involve friends. If you have terrible pain, maybe a pain clinic. Involve your sickle cell treaters. If you have kidney problems, nephrologist, use your friends, because it's a team approach. Thank you.
Thank you so much, Dr. Patterson. And again, we'll have a few moments for questions after all three of our speakers. I'd like to welcome up now Dr. Patrick Hines. Dr. Hines is a pediatric critical care physician, physician scientist, and founder and CEO of Functional Fluidics. You would have heard him speak yesterday as the keynote starting off the conference. You know that we're in for a great talk this afternoon. Dr. Hines is a professor of pediatrics at Wayne State University School of Medicine. And for more than 25 years, his clinical and research work has focused on red blood cell physiology and sickle cell disease, including advancing approaches to improve how the disease is studied and ultimately managed. Dr. Hines.
I'm just going to avoid the stage altogether. Should I put it on presentation mode? So I'm going to talk about sort of my day job, which is pediatric critical care, general and cardiac. And folks often ask in my world, like, why are you going to all these hematology, sickle cell disease meetings? And I talk with some of my colleagues who are not hematologists, but who see sickle cell patients, that one of the things that I think is really important about sickle cell disease is the multidisciplinary nature of it, and the fact that we're understanding so much more about it. It really takes a community of folks to support our hematology friends, because people with sickle cell disease have primary kidney issues and heart issues and lung issues and neurological problems. So there needs to be folks who are outside of hematology who have an interest in sickle cell disease supporting it, and I'm really glad to see that there's a lot more of us non-hematologists with a major interest in sickle cell disease. So really excited about that. So my talk is going to be about some of the areas of emergency that we see in the pediatric critical care setting. I'm going to focus a little bit more on sort of the unique biology of sickle cell disease and how that informs how we think about the management of some of these problems in the ICU setting. So, my conflict of interest is still that I have equity interest in Functional Fluidics, which develops red blood cell functional assays, some of which are referenced in this presentation. So I want to make sure you guys have that context. And so it's just a pain crisis. So I hear this a lot. And as you've heard before, it's a lot more than just pain, and there's often things that are happening in individuals with sickle cell disease that do not present as pain. And so I'm going to start with a vignette. So 4-year-old girl with hemoglobin SS disease presenting with arm and back pain. The first hour on arrival, she has a fever, temperature of 38.6. Pain is 8 out of 10. She's been coughing for 2 days. Respiratory rate is 32. She's satting 94% on room air. Her chest is clear. The x-ray is clear. She receives IV fluids, morphine, ceftriaxone, given the fever. No chest film is done, and she has no complaints of chest pain. Hour 4, pain's improving. She's sleepier. It's attributed to morphine. Her respiratory rate is now down to 26. Saturation is 92, and she's perceived to be getting better, and she's not re-examined. Hour 8, she's breathing at 48, grunting. Her SpO2 is now down to 86. She now has a new left lobe infiltrate, and she is intubated in the pediatric ICU within the hour. This is a similar scenario, if you guys recall the story that I told you about Eric yesterday, of a patient who was sedated, had some respiratory depression, and developed issues that became emergent at that time. The signals are already present. So 94% was her fall from her documented baseline of 99%, but they didn't know her baseline. So it's important to ask. We talked about baselines, and that's why they're so important, not just hemoglobin, but vitals as well. Fever plus cough in sickle cell disease is acute chest syndrome until proven otherwise. So you do not need an infiltrate on the X-ray if you have this constellation of symptoms. Opioids plus splinting from rib and back pain reduce tidal volume. So treating pain is not just about comfort, but it's actually about being able to breathe normally when you have pain in your chest, because hypoventilation is one of the main reasons why pain can escalate into acute chest, and we see that all the time in the pediatric ICU. So none of these needed a new test, and this is coming from the test guy. It needed a different framework. So the risk of sickle cell-related death in the pediatric ICU. So in this study of 3,300 children, over 5,000 pediatric admissions, we see that about 1.8% of admissions ended in death in the pediatric ICU, and that's 2.8% of the unique children in this particular study. 21% needed invasive respiratory support, and 12.5% actually had stroke. And so we're going to talk about stroke as one of the complications as well. And here you see the odds of death with the different diagnoses. And you see the greatest odds are in individuals who require invasive respiratory support. They're the ones who are at the greatest risk of dying in the pediatric ICU setting. A child compensates until they don't. So this is where it's important to understand the difference between pediatric physiology and adult physiology. So let's break this down a little bit. So the same insult produces a different trajectory in the 4-year-old child versus the 24-year-old adult. So the first is you have small resting lung volume, okay, in the pediatric patient. A compliant chest wall. So what does that mean? So cartilaginous ribs give less outward recoil to hold the lungs open. So splinting from rib, sternal, or back pain removes what little compliance there is, which puts pediatric patients, particularly the younger they are, at more risk for atelectasis when they hypoventilate, which creates more hypoxia, which creates more hypercapnia, increases in CO2, which can drive more of the sickling physiology. High metabolic demand, so kids have higher resting metabolic rates, which also can reduce their reserve. Vital signs stay normal until they don't, and they can drop precipitously. Anyone who's had to intubate a child or certainly an infant realizes that. With adults, when you're learning to put in breathing tubes with adults, you feel like you have a lot of time to intubate, particularly for the unskilled operator. But for smaller kids, you do not have much time at all. And once they're, you have to paralyze them to be able to get the breathing tube in, their saturation can drop really quick, and in the context of sickle cell disease, that can be pretty catastrophic. So the sequence is from rib or back pain, splinting, opioids to treat the pain, but it's a balance, right? Reduced tidal volume, atelectasis, regional alveolar hypoxia, so areas of the lung that become more hypoxic where the blood is not receiving oxygen, more polymerization in the pulmonary microcirculation, and this is how pain becomes acute chest syndrome. So our favorite curve in hematology is the oxygen saturation curve. And so the red line represents the sickle cell patient versus the normal in blue. And so at baseline, sickle cell the oxygen saturation curve is right shifted, which basically means that a given pressure of oxygen, you're going to be satting lower, right? Because your hemoglobin does not have as high of an affinity for oxygen. That's important as we think about this physiology. So why does this shift? So you've got 2,3-DPG and chronic anemia. You've got lower oxygen affinity of hemoglobin S, CO2 retention from pain, although it's not, I want to make sure I get the right perspective. You don't get the same type of hypoventilation risk in people with sickle cell disease that are treated with opioids as you do in the non-sickle population or the more opioid naive patients, but it does happen, and the consequences of it happening are pretty significant. So what does this mean? So at any oxygen tension, the saturation is lower, and a small further fall in tension produces a large fall in saturation. So little flat reserve actually remains. So the rule that follows is a saturation is interpretable only against the child's own documented baseline. So it's important as we think about baselines that we do, and we think about hemoglobin all the time, but also think about that baseline oxygen saturation in that child. Because if their baseline's at 94% and they're coming in at 94%, that's reassuring, and they may not need additional support or transfusion as somebody that actually has a lower saturation than their baseline. So 2 parallel injuries from one cell. So I split them into 2 categories. So there's mechanical and there's chemical. So mechanical is really the mechanical obstruction of the microcirculation due to things like rigidity and deformability and sickling that everybody is pretty familiar with. And now that can obstruct a small diameter vessel. But chemically, we also have increased free hemoglobin, which sequesters nitric oxide that affects the vascular tone, and that can cause vascular constriction and also result in a reduction in microvascular blood flow. Both converge on the pulmonary circulation. I mean, oftentimes these patients have baseline elevated pulmonary vascular resistance, even if it's not at the level that would define them as having pulmonary hypertension. It is still elevated, and they are still sensitive to additional hemolysis, infection, and hypoxia in that context. So it's very important to think about that, and we think about that a lot in the ICU setting, and maintaining normal oxygenation through whatever means we have available are really important. So acute chest syndrome is a final common pathway. So one syndrome, multiple mechanisms, which is why a single treatment reflex is not enough. So in 46% of documented acute chest syndrome cases in this particular study by Vachinsky, the cause was never identified. So in 29% of the ones where we did see a cause, infection was a cause, including atypicals and viruses. Pulmonary infarction in about 16% of the patients, and in 9%, fat embolism or marrow infarct. So multiple mechanisms driving this. Antibiotics alone will miss most cases, but withholding them is not an option in the context of acute chest. Incentive spirometry. So one of the things that we often forget about is very inexpensive. It's available to everybody. We often don't do it. So keeping those lungs open, treating atelectasis is a huge thing that we can do to prevent decompensation in the context of sickle cell disease. Supporting the failing lung. So the escalation ladder. So just non-invasive oxygen. Then supporting with pressure with non-invasive ventilation. Intubation, ECMO. So with ECMO, and I've taken care of more patients with ECMO and sickle cell disease than I'd like to recall, but the 52% survival rate on sickle cell patients with ECMO, but hopefully you guys never have to manage that, but we do have protocols for it. Ventilator settings in which sickle cell disease differs. So oftentimes when we're having a child on the ventilator, we will allow some permissive hypercapnia. This is more of an issue in the context of sickle cell disease. So I always tell my residents and fellows, you want to avoid that in that context. So basically, elevated CO2 is going to create more acidosis and lead to more sickling. So the other thing that we think about is positive in-expiratory pressure, or PEEP, that raises right ventricular afterload, which can be good in some situations, but in the context of sickle cell disease, when you already have a baseline elevation in pulmonary vascular resistance, that can be very problematic on that right ventricle, which may be struggling. Nitric oxide. So there's not great data with nitric oxide in the context of hypoxic respiratory failure in terms of significant improvement. So the literature would suggest that we probably should not do that very often. Anecdotally, I do it probably more than most, because I've seen it in improved situations where I feel like that oxygenation, that pulmonary vascular resistance is an issue. So acute stroke, I'll go through this quickly since we've talked about stroke in terms of being able to recognize the early signs, imaging without delay, transfusing urgently, protect the brain. So a little bit about brain protection. What does that mean? So in the ICU setting, we want to reduce the metabolic demand, cerebral metabolic demand, to prevent injury. So normothermia, not hypothermia, but normothermia, normal glycemia, normal or slightly high normal blood pressure, seizure treatment, sometimes seizure prophylaxis, because again, you want to keep that metabolic demand as low as possible. I'm going to skip that one just for time, but what to measure and when. So baseline pulse oximetry, and even in an outpatient setting, to have that established and documented in the chart. Transcranial Doppler, obviously. Sleep history with every visit. So nighttime hypoxia, that's a big issue. Or cumulatively, that can cause issues with pulmonary vascular resistance. And symptom-triggered pulmonary function tests and echocardiography are important baselines to understand. Functional red blood cell indices are an emerging thing that I'm hoping is going to give us more insight into who is at risk, so we can think more about prevention. And I'm going to go to the 4 things I want you guys to carry out of this room. Is that first, pain is the loudest signal, but not the most dangerous one. Okay, so I want you to think beyond pain. Lung is where this disease really declares itself. Every child needs a personal baseline. It's really important in kids because there's so much heterogeneity. And measured biology belongs alongside counted crises, because this is going to be one of the things that helps us understand an individual's unique risk for certain types of disease outcomes. So recognizing critical illness here is not about knowing more syndromes. It's about not letting the pain crisis be the entire frame. So with that, thank you guys for your attention, and any questions, I'll be happy to take them.
Thank you again to our 3 speakers for this afternoon. I'd ask each of you to please come on up to the table, and we'll have time for a Q&A. So we've got about 5 minutes. So Dr. Hines, Dr. Patterson, Dr. Fasipe. There you go. Excellent. All right. Are there any questions for our speakers? I was going to say, I'd be surprised if there aren't questions. There was a lot of stuff to dive in there. Okay, Karen, your hand was up first. Dr. Crow, you're up next.
Good afternoon. Thank you very much. This question is for Dr. Patterson. So I'm interested, we've heard a lot about the care plan and the need for a care plan, and I 100% agree. And you said you personally do one in 2 EMRs. So if a Hamilton patient, say, came to Lake Ridge Health, how do we know the care plan is there? Do you know how would we know it's there? And if not, this kind of goes back out into the air. We really need a standardized care plan that's built so that we don't have to do this individual. We all agree it's a best practice. So I'm just interested in that info. Thank you.
Yes. The joys of a regionalized center is that our care plans are visible. So in Hamilton, we have 2 healthcare organizations. We have St. Joseph's Healthcare and we have Hamilton Health Sciences. Our clinic is out of Hamilton Health Sciences, but our patients mostly go to our center for sort of streamlined care to St. Joe's, which is a different EMR, but still Epic. So it doesn't, my patient care plans, my patient care coordination notes are not cross-organization. So I will enter them in HHS because that's what I do in clinic, and then I will open a second EMR and I will go through and I will copy and I will paste and I will reformat individually for every patient that is in Hamilton. It's super fun.
But like what section? I don't think it sounds fun at all.
So
but
that, I agree. But that part only shows up in our EMR. It will not show up in an EMR outside of Hamilton Health Sciences, even though Epic is connected. Okay, so
yes.
for my folk who are likely to get admitted, because we're a regional program, if they're likely to be admitted outside of Hamilton, I'll actually put the whole patient care coordination plan in the bottom of my note. And I will literally say, if this person presents, please do these labs, please do these medications, and start here. It's really wordy. My notes are very, very long, but I try to make them comprehensive. And interestingly, I got a referral from an out-of-province patient who actually had an emergency room plan, which I've started to input into the bottom of my notes, of like, hey, these are the reasons that people present for care. Start with an NSAID if the patient can have it, some Tylenol, and an opioid dose. Here's what they take at home. This is where I think they should start, and then call hematology if they're there. So for people, like I don't have a simple answer, but I know that there's so much variability between how one patient and another person living with sickle cell disease may experience their sickle cell complications. So I try to reflect that as much as I can, though no individualized care plan is perfect.
Thank you.
Kevin Kuo from Toronto, Canada. This question is directed to Dr. Hines. Hi, Patrick. Thank you for coming up this weekend and spend time with us. I know you've got better things to do than to come here. But the question for you is, have you identified any functional markers, because clearly is your forte. Have you identified any functional markers that would identify patients who are at risk of needing critical care? Aside from, as you know, a long, long time ago, there was a study by the National ACS group with soluble PLA2. There isn't really anything out there that can guide us.
Great question, Kevin. So the first thing is respond to a comment. There is nothing I could be doing better than being here in Toronto with you guys. So let me answer that question first. So the prediction of critical illness is obviously something I'm really interested in, and functional biomarkers. And so at this point, we don't have, other than that data you talked about with SPLO2 and acute chest syndrome, data that is shown to be predictive of critical illness. I think we can make some inferences about the functional markers that we do know about that have been shown pretty reliably to be predictive of a steady state's individual risk of having a future pain event, which one of those markers is adhesion index, which looks at both VCAM, vascular cell adhesion molecule, and P-selectin as a composite. And folks that are above a score of 2, for example, have a 50% probability of having their next event within about 10 days, whereas folks who have a 0, both those markers below their threshold, 50% probability of having their next pain event beyond 100 days, so pretty infrequent. The way that sort of contributes to what we think about in an ICU setting is that those folks that have higher adhesive or stickiness indices of their red cells are certainly at more risk for having pulmonary vascular micro-occlusive events. We extrapolate to think that would put you at increased risk for acute chest syndrome. Folks that have more hemolytic profiles, which we can look at in terms of functional membrane stability, which is predictive of folks who are more risk of having hemolytic issues before those hemolytic issues actually happen. We think in the acute care setting, when they have more hypoxia, more stress, more inflammation, will be more at risk for pulmonary vascular constriction, for example. And so the hope is that we'll be able to be a much more sort of preventative minded when we see those patients to prevent that progression to acute chest that leads them to inpatient admission and ICU admissions. But right now, we need a lot more numbers to be able to be better predictive of specific acute care episodes.
I have one question for Dr. Fasipe before we wrap up our session this afternoon. So, Dr. Fasipe, you had talked about quality improvement frameworks, and I wonder if you can speak with us a little bit more about how people can learn more about quality improvement approaches, and if there are any conferences that are focused on quality improvement in sickle cell.
Thank you. So when I was mentioning how quality improvement sometimes can be a bad word or it creates panic, I had this complicated relationship with it for a while. A couple short answers. One, there's something called the Institute of Healthcare Improvement. IHI, you can find them online. They have tons of free resources, YouTube and on their website, free, and you can get a crash course and even more intense training in quality improvement. Groups like American Society of Hematology have a quality improvement training curriculum where you can actually apply your hospital project to, and they'll help you cultivate it and champion it to your institution. And then in conferences now, so most of our hematology conferences, they include now abstract submission categories for quality improvement, which wasn't always the case. And then you can actually go to quality improvement conferences. I found there's one that our institution now does just for hematology oncology, and it's a whole bunch of people discussing their hospital goals together. It's worth learning because it allows you to then speak to your leaders. They see you more as a partner that wants their goals to also be successful, in addition to the successful goal that you want of better patient care, better quality care. So cost, care, experience, all together. But yeah, thanks.
Thank you. All right, everyone, join me in thanking our three fantastic speakers again. Wonderful. Thank you all. All right.